I'm so delighted to meet you in the program of Tea Kadai Bench.
Good morning. Good morning, sir.
Good morning.
Sir, 62 years female presented with drowsiness.
Okay.
So, how will you approach this patient, sir? Generally, in textbooks, the approach to drowsiness or altered sensorium is very extensive and perplexing, sir.
True.
So, can you say in a simple way and in a practical manner? So, how will you approach that?
Yeah, so this is a very common occurrence. So most of the practitioner face these kind of patients either in outpatient setup or even those who govern hospital as well. So the thing is, any patient who presents with altered sensorium, the first most important, you have to look for ABC, airway, breathing and circulation. You are all aware of that. Once these will be taken care, then you have to divide the causes of altered sensorium broadly in two categories. One, the causes originating from the brain. Another one, the causes originating other than the brain. Okay. So the most important thing is we don't have any kind of imagings at our hand. See, most of the OP setup and even I could say mid-scale hospitals, they don't have CET and MRI. So there is a quick assessment by which you have to take a call in such a way that whether patient requires imaging very immediately or you can postpone. So any patient who is received by you, immediately you have to take a call. So generally the history would be very helpful.
So, generally, when will you rush for imaging, sir?
Yeah, that's a good question. So when somebody presents with history of headache, vomiting, followed by drowsiness or loss of consciousness, you can think of subarachnoid hemorrhage. Somebody has fever for a couple of days followed by altered sensorium, always keep it in mind about possibility of meningitis. So you have to rush for imaging. Suppose when somebody has history of trauma, then definitely it may be a traumatic intraparenchymal hemorrhage or traumatic subarachnoid hemorrhage. You have to go for imaging. And apart from that, few signs should prompt you to go for imaging. For example, when you examine at the time pupillary asymmetry, for example, one side you may have dilated pupil, that indicates probably third nerve compression secondary to uncal herniation or any tumor might have pressed third nerve. So pupillary dilatation, especially one side dilated people, and if you witness some form of neurological deficit, for example one side weakness or cranial nerve deficit, facial weakness, these are the few signs should prompt you to go for quickly for imaging. When it comes to imaging, we have two options. Either we should go for MRI or CT. Sometimes you may be forced to go for both the imaging as well. For example, when you suspect stroke, for example, somebody presents with right side weakness, you are suspecting left side MCA territory infarct. If you want to delineate the nature of the infarct or vascular occlusion, better you just go for MRI, because MRI is able to detect the infarct very early. So you have to mention MRI with diffusion weighted imaging. They are doing now by default. So diffusion weighted imaging. So because why we are specifically going for MRI? Suppose if somebody presents with weakness suggestive of stroke, if they come within 4.5 hours, so that patient has one opportunity to go for thrombolysis. So CT may not find early infarct. So we prefer MRI over brain if you suspect infarct. Suppose if you think that the patient has subarachnoid hemorrhage, either traumatic or history reveals that features of subarachnoid hemorrhage. Sometimes subarachnoid hemorrhage may present with neck stiffness as well. So at that time, CT scan scores over MRI generally. But otherwise, for example, suppose if you suspect meningitis, if you go for simple CT, may not show any finding. If you go for simply MRI, then with MRA may not show any findings of meningitis. You should specifically ask for MRI contrast, which will tell us the enhancement of meninges suggestive of meningitis. So these are the signs which will force you to go for imaging. Suppose when you receive a patient with drowsiness or altered sensorium or to some extent stupor or coma, but you are not able to make any kind of neurological deficit or no pupillary asymmetry, there is no neck stiffness, then probably you have to think of causes below the neck. So I used to say always, you just divide the causes of coma altered sensorium into two parts. One is above the neck, I mean the causes arising from the brain or structures surrounding the brain, including meninges. Then another one is causes below the neck. So when the causes below the neck means think of first, so you can easily remember. Okay, so think of heart, whether heart can produce altered sensorium to a variable extent. Sometimes when patient presents with severe MI with hypotension, they may be in obtundation, something like drowsiness. So check one ECG that may reveal MI. Sometimes if they have arrhythmias, that may produce altered sensorium. Arrhythmias may lead to some form of stroke also too. And suppose with respect to lung, whether it can produce altered sensorium, yes. If they go for hypoxia and hypercapnia. Hypoxia, of course, you can detect hypoxia with simple pulse oximeter to some extent, but hypercapnia won't be revealed by monitor, of course. So patient has to undergo ABG, which can reveal increased PCO2, or otherwise we used to say carbon dioxide narcosis may result in altered sensorium. That's one. Heart we have seen, then lungs, then you just below, then liver. Yes, liver produce, yes. Hepatic encephalopathy, so do LFT. Then if possible, suppose patient is in ICU setting, probably intensivist, or probably you can bring radiologist in and they will do liver ultrasound. If it shows features of chronic liver disease, go for serum ammonia very immediately. So think of hepatic encephalopathy. Then what about kidney? Yes, uremic encephalopathy. Suppose elevated urea somewhere around 180, 200 and creatinine 6, then think of uremic encephalopathy. So these are the few causes. So organ wise, heart, arrhythmias and MI can be dealt with ECG. Then hypoxia and hypercapnia, I mean with respect to lung, can be detected by ABG. Then hepatic encephalopathy, do LFT and serum ammonia and ultrasound. And if you do urea and creatinine, then you can easily rule out uremic encephalopathy very quickly. Then apart from that, through blood, generally your couple of abnormalities can be ruled out very immediately. For example, hypoglycemia, hyperglycemia. If you do simply one CBG, that will tell us whether it's a patient is an hypoglycemic altered sensorium or a patient is heading for ketoacidosis or HHS syndrome. Then through blood you can assess hyponatremia and hypernatremia. Then to some extent hypomagnesemia and hypermagnesemia, hypocalcemia, hypercalcemia can produce altered sensorium. But through the blood, what generally we look for, that one is abnormalities in the glucose, hypoglycemia and hyperglycemia, then hyponatremia and hypernatremia. Please remember that hypokalemia, hyperkalemia is not linked with altered sensorium. If somebody has hypokalemia, you can't say this hypokalemia is responsible for altered sensorium, because potassium is associated with muscle. So probably you can put blame on hypokalemia when somebody has cardiac arrhythmias, that is related with muscle, then paralytic ileus, intestinal muscles, then skeletal muscle, you have quadriparesis. So hypokalemia and hyperkalemia can't produce altered sensorium. That you have to be mindful about that. So once you just draw the blood and check for hyperglycemia, hyponatremia and hypernatremia, then after doing imaging, then after doing all kind of liver, ABG, and after doing all kind of screening tests for organ dysfunction, then after ruling out hypoglycemia, hyperglycemia, hyponatremia, hypernatremia, then still there are few mystery causes you have to be taken care. One important is myxedema coma. You have to go for thyroid function test. Then sometimes Addison disease, they may present with hypotension, hypoglycemia, restlessness, altered sensorium. So you have to go for steroid assay. So what I want to insist that when somebody presents with altered sensorium or drowsiness or coma, quickly take a call whether this patient subjected to imaging or not. I mean, the whether causes arising from the brain itself or causes outside of the brain, I mean below the neck. Suppose if you think that there is no hardcore neurological signs suggestive of brain pathology, then think of extra brain causes, I mean metabolic causes with a below the neck. So quickly you do CBG, you can rule out hypokalemia, hyponatremia or hypernatremia and glucose abnormalities. Draw the blood for LFT abnormalities and renal abnormalities. Do one simple ABG, you can rule out hypoxia and hypercapnia. Do ECG. I think that these blood abnormalities and organ dysfunction and ECG, ABG, everything can be finished up within 30 minutes very easily. Suppose if you think that if there is no cause arising from the brain, then definitely you can think of below the neck, do all these blood tests, then within half an hour, definitely you can delineate what kind of disease you are dealing with. Suppose now you are sure that there is no need of brain imaging, but after drawing blood for all kind of abnormalities, you are not able to detect any abnormalities. Then, as I told you, two endocrine abnormalities, myxedema coma and Addison disease. But no, these results will take some times. These endocrine abnormalities will take at least 12 to 24 hours. But you have to take a call. But despite doing all these things, but still you are not able to come to conclusion, then think of 5 yes generally. So can you enumerate that 5 yes?
Yeah, I have little bit idea about that, sir.
Okay.
So first is sepsis.
Okay.
Then seizure.
Another yes is seizure.
Another is
Yeah.
seizure. Then third one is psychological factors.
Another yes. You mean
another
the P silent one.
Yes,
Yes, you are
yes.
telling psychological cause.
Yes, and then another S is sedative.
Sedative
Yes, sir.
overdose. Yes,
Yes.
good.
Then stroke, heat stroke, sir.
Okay. So this 5 S's, I think that you have to be very careful. Your MRI and CT may be normal and your blood abnormalities may not be detected, but probably even after 24 hours, probably your thyroid function, probably you can easily rule out Addison as well. But still, it is so vague, then think of this 5 S. So generally, sepsis, probably I think that they will have normal count or they may have leukopenia or leukocytosis as well. They may have associated thrombocytopenia. So normal count may not exclude sepsis, but generally when you think of sepsis, I could say it is a diagnosis of exclusion. So you can't say immediately it is septic encephalopathy. So probably when you rule out other abnormalities, suppose if patient attenders gives history of fever, then you have some kind of localizing signs for infectious origin, then you can strongly suspect septic encephalopathy. But when you suspect sepsis, and probably you have to draw blood culture, 3 samples at different sites, and of course you have to do urine culture, and you can do some biomarkers, probably procalcitonin you can do. Suppose if you have elevated procalcitonin, some kind of blood abnormalities with the history of fever, but there should not be no neck stiffness, okay, then probably you can think of septic encephalopathy. But and another one is, I told you another seizure. Sometimes patient might have had seizure in restroom, bathroom. Probably the attenders might have not noticed. The patient might be in postictal state. So they may bring the patient only in the postictal state. So at the time patient doesn't have any kind of motor activity. They don't have any seizure episode obviously. So you may get confused. So postictal state. And another one is, if somebody had the GTCS at house, then followed by this GTCS will be slowly getting converted into mild subtle seizure, or there won't be no convulsive movement at all. That is called a non-convulsive status epilepticus. They don't have any motor movement outside, but they will have ongoing epileptiform activity in the brain that can be detected only by EEG. So you should have high index of suspicion. Then another is psychological cause. That must be the last one. Probably once you rule out, the imaging is normal, then below the neck all the causes normal, then as I told you, all the causes ruled out, then probably you have to take psychiatrist on the board. Then heat stroke. So especially in the summer climate, they will have very high grade of fever. This requires high index of suspicion. The patient needs to undergo CPK. So this is the
Sedatives.
what are the 5 years? You just once again repeat, even after ruling out all the causes, the hidden 5 years, please tell me once again, repeat. Sedative, seizure,
psychological factors,
psychological factor, sepsis,
and heat stroke.
Yeah, heat stroke. These 5 years have to be remainful. So you can say now we have to come to a stage where something called rapid fire. When somebody comes with drowsiness, how you can do rapid fire approach. When somebody is presented with drowsiness or altered sensorium, quickly assess for the stability, I mean ABC, airway, breathing and circulation. Once you are very much convinced, then you have to divide whether patient requires imaging very immediately or not. If imaging is not required immediately, immediately you do just CBG. If CBG is normal, draw blood for all kind of abnormalities and do ABG, rule out hypoxia and hypercapnia, do one ECG, rule out arrhythmias and MI. Then suppose wait for half an hour. Once results come, nothing is there, you are not able to find out anything, then go for one order for test for Addison disease and myxedema coma, I mean thyroid function test. So wait for these tests, okay, because these tests will take at least 12 to 24 hours for these 2 endocrine abnormalities. Then the suspect the remaining 5 causes. But even assessing all these things, you are not able to extract anything, but patient doesn't have any hardcore neurological signs. But if you don't have any signs, but at least you just go for MRI and CT, probably we may miss some hardcore neurological sign also. So first you have to give paramount to the structures of cranium, that is brain. So this is the way you can rapidly evaluate how to approach the drowsiness. In this patient, 62 years old female patient presented with drowsiness. So we approached with rapid fire. So we immediately could say the patient didn't require any imaging. We did ABG, PCO2 was 110. Then we retrospectively asked the patient whether the patient had any history of COPD. Then the patient attenders revealed that the patient had COPD. So to eliminate PCO2, patient was intubated, connected with mechanical ventilation. Then after 24 hours, with the help of IV, broad spectrum IV antibiotic and steroid, and with the help of mechanical ventilation, patient was extubated. Then patient did well. So this is the rapid fire approach. I think that I sincerely hope this one would be immensely helpful. Thank you.
Okay, thank you.